Hey, BC here. Welcome to BC Nephro. Today I'm going to talk about nephrotoxicity, specifically how some other specialties screw up the kidneys. So for my first talk on this, my first video on this, I'm going to talk about an important specialty that screws up the kidneys. I know what you're thinking, oncology. Seriously, if you were thinking cardiology, go watch TikTok or something. Today I'm going to talk about oncology, specifically different chemotherapy, different anti-cancer therapy, which can cause nephrotoxicity. So I find this extremely interesting for a number of reasons. First, there are a number of different mechanisms of chemotherapy, of anti-cancer therapy, and a number of different mechanisms of nephrotoxicity. Check out a link in the description below to an article at bcnephro.com to talk about some of these things. Second, it's important because these patients have cancer, so we're in the patient's best interest to often say they can't take this drug anymore and try to find how the drug can be used. So today I'm going to talk about a couple things that I find more interesting, some of the newer. First being immune checkpoint inhibitors, and the second being angiogenesis inhibitors and the ways they affect the kidney. Again, for a more detailed list about some of the other agents and the ways they cause nephrotoxicity, renal effects, check out the link in the description below to an article at bcnephro.com. So first, immune checkpoint inhibitors. Super cool, allow the immune system to attack the cancer. Not surprisingly, unmasking, unchecking the immune system allows different types of autoimmune type conditions, one of them being interstitial nephritis. So this is a thing that's seen not infrequently with the use of these drugs. So a couple of interesting things about this. First, it's not uncommon for the presentation to be smoldering indolent. A study showed that the median incidence was about 14 weeks, so it may not happen after right away. And again, I've seen a number of indolent cases that with a smoldering, slowly increasing creatinine, and you need to figure out, is it the checkpoint inhibitor? Is it something else? Is it nephrotoxicity from another chemotherapy agent, a non-chemotherapy agent, something else going on? So often do a kidney biopsy to figure this out. But one of the really interesting things about this is there's an association between the use of the checkpoint inhibitors and interstitial nephritis and the use of proton pump inhibitors. So proton pump inhibitors, well-known cause interstitial nephritis. And the idea is this: the proton pump inhibitors in the system has a propensity to cause an interstitial nephritis, but the immune system is not allowing that to happen. Then you add in the checkpoint inhibitor, removes that blockage, then you get interstitial nephritis. So in my opinion, if you have a patient that you're using a checkpoint inhibitor, thinking about using a checkpoint inhibitor, has had interstitial nephritis from a checkpoint inhibitor, wean them off the proton pump inhibitor. Stopping a proton pump inhibitor invariably is not going to work. The reflux is going to flare. It needs to be weaned off, and if you wean it off, can have a pretty significant success rate there. So the second thing is they're very sensitive to steroids. So steroids is a good treatment for these checkpoint inhibitor interstitial nephritis. Now moving off to the angiogenesis inhibitors, there's VEGF inhibitors, there's tyrosine kinase inhibitors, and they cause a couple different nephrotoxicities. The first they can cause is hypertension, which is not surprisingly, you screw up the endothelium. The endothelium has nitrous oxide, other vasodilatory factors. So you impair that, you get hypertension. And some people think if you get hypertension from one of these agents, it's a sign that the agent's working and having an antineoplastic effect. So it might be a good sign, although depending on the severity of the hypertension, you may need to treat it. It is recommended to use renin-angiotensin system blockers like ACE inhibitors or ARBs, effective for this. Another thing that can happen is thrombotic microangiopathy, a drug-induced TTP can happen. In this case, you might have the microangiopathic hemolytic anemia. You might have the renal effects with acute kidney injury. And often there's an association with proteinuria, which can be quite severe with some of these drugs. Often is recommended if the proteinuria is severe, they say more than 2 grams, hold the drug and then try to reintroduce it at some point in the future. Less than that, you're going to treat it with an ACE inhibitor or angiotensin receptor blocker. Full-blown nephrotic syndrome, it may be recommended not to use the drug. So there you have it. Interesting, at least in my view, nephrotoxic effects of some of the anti-cancer therapies. Again, check out a link to the article at bcnephro.com, and let me know what you think, what you want to hear about, your comments, experience with these types of drugs. And until next time, have a good one.